Welcome to the Deep Dive, the show that extracts the most important nuggets of knowledge you need to be truly well-informed. Today, we're embarking on a critical deep dive into integumentary problems, drawing from Lewis's medical surgical nursing. When we talk about the skin, we're not just discussing a simple covering. It's a dynamic, vital organ, a true storyteller reflecting our overall health. And surprisingly, it's susceptible to a vast array of issues that can really impact a patient's life.
That's absolutely right. And our mission today really is to arm you, our future nursing colleagues, with an essential toolkit. We want to equip you with the knowledge to confidently understand, assess, and manage common skin conditions and cancers. Think of this deep dive as your shortcut, a way to get well-informed and confident in integumentary care. We'll be emphasizing that critical nursing process you'll use in real-world clinical scenarios, helping you think like a nurse for those NCLEX-style questions.
Excellent. Yeah, we're going to cover everything from the profound impact of environmental damage, the critical nuances of various skin cancers, all the way through to infections, allergic reactions, and those practical patient-centered nursing strategies, the ones that truly make a difference at the bedside. So let's truly peel back the layers and understand what happens when our skin's incredible fortress is breached. Because when that first line of defense is compromised, the ripple effects on our body and, well, our patients' lives are pretty profound.
Indeed, they are. And a major environmental hazard we absolutely have to address is sun exposure. What's crucial here, especially for new nurses, is understanding it's not just the painful sunburn from UVB light that's dangerous. UVA, which primarily causes tanning, is silently damaging elastic tissue and contributing to cancer, often without any immediate discomfort, that healthy glow so many patients want. It's actually a sign of significant cumulative skin damage. UVC light, thankfully, is blocked by our atmosphere. So the big picture here, UV damage isn't just about one bad burn. It's a slow, cumulative assault. It leads to premature aging, the loss of elasticity, thinning, wrinkling light, and it significantly increases the risk for precancerous lesions like actinic keratosis, plus basal and squamous cell cancers, and of course, melanoma.
That idea of cumulative damage, it really changes how we should approach sun exposure, doesn't it? What's the most common misconception you hear from patients when you're explaining prevention? How do you tackle that?
Oh, that's a great question. Well, many patients still believe that sun exposure is harmless if they don't actually burn, or that tanning booths are somehow a safe alternative, which is just not true. My strategy is always to highlight the unseen damage. For instance, I explain that tanning booths emit UVA, and UVA has a strong link to all skin cancers. I mean, the damage starts from the very first visit. Wow. And get this, 95% of melanoma patients diagnosed before age 30 report using tanning booths. It's shocking.
Wow, 95%. That statistic alone should be a major wake-up call. So for sun protection strategies, we really need to emphasize comprehensive approaches with our patients. This means teaching them practical ways to create a physical barrier, right? Like protective clothing, sunglasses, wide-brimmed hats, darker, tightly woven long-sleeve shirts, or even just carrying an umbrella. And it's vital to avoid midday sun, usually 10 a.m. to 2 p.m. That's when, 80% of UV rays hit? And we have to shatter that myth that clouds offer protection. Up to 80% of UV rays can still get through them. So yeah, you can definitely get burned even on overcast days.
Exactly. And that naturally leads us to sunscreens. You can think of them in two main camps. You've got your chemical sunscreens, which absorb UV light, and then the physical blockers like zinc oxide or titanium dioxide that reflect it. The crucial part for us as nurses is making sure patients use broad spectrum products. That means they block both UVA and UVB. For daily use, an SPF of at least 15 is generally recommended. But for anyone with a history of skin cancer or significant sun sensitivity, an SPF of 30 or higher is really a must, and proper application is just so key. Apply it 20 to 30 minutes before going outdoors. Reapply every 2 hours. And remember, you need about 1 ounce that's roughly a shot glass full for a total body application. Don't forget those easy-to-miss spots like ears, toes, and lips. And of course, reapply after swimming. Sunscreens aren't truly waterproof, despite labels.
Right, water resistant, maybe, not proof. Okay, speaking of unseen threats, it's not just what hits our skin from the outside, is it? What about the medications our patients are taking? This feels like where a nurse's vigilance becomes absolutely critical.
Oh, definitely. Many common drugs, and sometimes surprising ones, like certain antidepressants, antimicrobials like tetracycline, NSAIDs like ibuprofen, even diuretics like furosemide ointment, they can dramatically increase sun sensitivity. It basically turns a normal day into a potential severe burn risk. The reaction looks a lot like a really bad sunburn, but the trigger is internal. It's the drug.
So our role here is absolutely crucial then. We need to always screen for photosensitizing drugs in a patient's med list and diligently teach them about needing extra protection. Because, yeah, a typical day in the sun could suddenly cause a severe reaction for them, precisely. And that brings us right to the absolute cornerstone of skin assessment, the ABCDE rule. This mnemonic, it's your quick mental checklist for spotting suspicious lesions that might signal skin cancer. So
Wow.
A is for asymmetry. One half of the lesion looks different from the other half. B is for border irregularity. The edges are ragged, notched, maybe blurred. C stands for color change and variation. Think varied pigmentation shades of tan, brown, black, or even red, white, or blue all in one spot. D is for diameter, usually 6 millimeters or more, roughly the size of a pencil eraser. And E is for evolving. This one's huge. Any change in appearance, shape, size, color, elevation, any other characteristic over time. That's often the most critical warning sign.
Got it. A, B, C, D, E, asymmetry, border, color, diameter, evolving. So for a nurse, remembering this means knowing that any persistent lesion that doesn't heal, or any change in an existing mole or spot that warrants immediate follow-up with a healthcare provider. Early detection really does make all the difference.
Absolutely. It's a powerful and practical tool for nursing students, and all nurses, really.
Okay, now let's zoom in on skin cancer itself. It's actually the most commonly diagnosed cancer globally, which is kind of startling. But the good news, I suppose, is that its visibility often leads to earlier detection. And that generally means a more favorable prognosis compared to many internal cancers if we're vigilant.
True, visibility helps. But understanding the risk factors is still crucial for prevention and screening. Individuals with fair skin, light hair, light eyes, they're at higher risk because they have less melanin, which is our natural sun protection. A history of outdoor sunbathing, living near the equator or at high altitudes, and definitely a family or personal history of skin cancer are significant risk factors. And from a health equity perspective, this is really important for nurses to know. Darker-skinned individuals, while having a lower overall incidence because of more melanin, they often experience delayed diagnoses. Their melanomas tend to pop up in less pigmented areas. Think palms of the hands, soles of the feet, mucous membranes, even under the fingernails or toenails. This makes detection trickier and means we need a really thorough head-to-toe assessment for everyone.
That's an extremely important point about health equity, something nurses absolutely need to keep in mind during assessments.
Okay, let's delve into the non-melanoma skin cancers. Specifically, basal cell carcinoma, BCC, and squamous cell carcinoma, SCC. These are the most common types, right? And thankfully less deadly than melanoma, but they can still cause significant problems. They typically develop in the skin's basement membrane, usually in those sun-exposed areas we talked about.
Exactly. Let's break down 3 key conditions here. First, actinic keratosis, AK. This isn't cancer yet, but it's the most common precancerous lesion. It's strongly linked to sun exposure, very common in older white populations. It looks like an irregularly shaped, flat, often reddish papule with kind of indistinct borders. Sometimes it has a hard, scaly horn on top. Now, this is critical for nurses. Because AK can progress to squamous cell carcinoma, treatment is usually pretty aggressive.
Okay, so AK is the warning sign, the precancer. What about actual cancer?
Right. Next is basal cell carcinoma, BCC. This is the most common type of skin cancer overall, and it's the least deadly. Good news there. But it's locally invasive. It grows, but it rarely spreads to other parts of the body, metastasizes. A classic look is a small, slowly enlarging papule. It often has a translucent or kind of pearly border. You might see tiny visible blood vessels on the surface. Those are called telangiectasias. Sometimes there's a central erosion or ulceration. Now, a critical point for nursing practice. Because BCC rarely spreads, patients might downplay it. They might delay seeking care. We need to emphasize that even if it's not typically deadly, an untreated BCC can cause significant disfigurement and local tissue destruction. It can really impact quality of life.
Got it. Locally invasive but still destructive if ignored, and the other main type, SCC.
Yes. Squamous cell carcinoma, SCC. This one arises from the keratinizing epidermal cells. It can be more aggressive than BCC. It definitely has metastatic potential, especially if it's left untreated for a long time. It often develops right at the base of an untreated AK. Risk factors, again, include sun exposure, but also immunosuppression and smoking. SCC can look different depending on the stage. Superficial SCC might be a thin, scaly, reddish plaque. Early invasive SCC might be a firm nodule with indistinct borders, maybe some scaling and ulceration. Late stage could be covered with a scale or horn. The key takeaway: compared to BCC, SCC has a greater potential to spread. So really detection and treatment are paramount.
Okay, BCC less likely to spread, SCC more concerning in that regard. So what does this all mean when we talk about melanoma? This is the one people really fear, right? The most serious type of skin cancer.
It is. Yeah, melanoma accounts for the majority of skin cancer deaths.
Okay.
It arises from melanocytes, those are the cells that produce melanin or pigment. And what makes it so terrifying is its ability to metastasize to spread to basically any organ in the body. Brain, heart, liver, lungs, anywhere.
Wow. So what causes it primarily? Still sun.
UV radiation is the main culprit, yes, from the sun or from tanning booths. It damages the DNA in the skin cells. While anyone can develop melanoma, again, those with fair skin, light hair, light eyes, are at highest risk. Genetics also play a significant role. A family history increases risk considerably, and so does the presence of dysplastic nevi, or what we sometimes call atypical moles. These moles tend to be larger than normal moles. They often have irregular borders and varied colors. They share some of the ABCDE characteristics we talked about for melanoma, but maybe less pronounced. Having these significantly bumps up your risk for developing melanoma, so it warrants much closer surveillance, regular skin checks.
Okay, so those ABCDEs we learned, they're not just a guide, they're absolutely crucial for melanoma detection then.
Crucial is the word. These tumors are often deep brown or black, but like I said, they can have irregular color, surface, and borders. You might see variegated shades, red, white, blue, gray, all within one lesion. Any lesion showing sudden or progressive changes in those ABCD characteristics, that needs immediate evaluation, no waiting.
And how is it diagnosed and managed? What's the interprofessional care look like?
Well, the diagnostic process usually starts with a dermoscopic examination using a special magnifying scope. If a biopsy is needed, the gold standard is an excisional biopsy. They remove the entire suspicious lesion. Shave biopsies are generally avoided because they don't allow for accurate measurement of the tumor's depth. And that tumor thickness, that's actually the single most important prognostic factor. We assess it using the Breslow measurement. That tells us the tumor's depth in millimeters. It's the key indicator for prognosis.
So thicker tumors mean a greater chance of spreading.
Exactly. Melanoma is staged from 0 to Y-hen, and that staging guides the treatment plan. Fortunately, stage 0 melanoma, which is called in situ, meaning it's confined to the very top layer of skin, is nearly 100% curable just by surgical excision. For treatment beyond stage 0, initial management is typically wide surgical excision, removing the tumor plus a margin of normal skin around it. For more advanced disease, nurses will see patients receiving adjuvant therapies, things like immunotherapy, which helps the body's own immune system fight the cancer, or targeted therapy, which uses drugs that target specific genetic mutations found in the cancer cells, like BRAF inhibitors. Chemotherapy and radiation might also be used.
That's a lot to manage. Okay, moving beyond cancer now. Our patients face a whole spectrum of other common skin challenges, right? Things nurses see all the time. Let's start with infections.
Absolutely. Bacterial infections like impetigo and cellulitis are very common. Impetigo, you'll recognize this one. It's highly contagious, characterized by these little vesiculopustular lesions that develop thick, honey-colored crusts, often seen on the face, especially in kids. For nurses, the key interventions are meticulous hygiene, teaching hand washing, using warm saline soaks to remove crusts, and administering topical or sometimes systemic antibiotics.
Honey-colored crusts, okay. That's a good visual cue. And cellulitis.
Cellulitis is a deeper inflammation down in the subcutaneous tissues. It presents as a hot, tender, red, swollen edematous area, but the borders are usually diffuse, not sharply defined. Patients often have systemic symptoms too, like chills, malaise, maybe a fever. Nursing care here involves applying moist heat, immobilizing and elevating the affected limb if possible, and administering systemic antibiotics. Severe cases might need IV antibiotics.
Okay. What about viruses?
When it comes to viral infections, herpes zoster or shingles is a really unpleasant one. It's a reactivation of the same virus that causes chickenpox, the Varicella zoster virus. It typically causes this linear distribution like a band or stripe of grouped vesicles and pustules along a dermatome. A dermatome is just a specific area of skin supplied by a single spinal nerve. That distinct pattern is a big clue. Patients usually have significant burning pain and neuralgia along that nerve path. Our nursing priority is encouraging prompt treatment with antiviral agents, ideally within 72 hours of the rash onset, to reduce severity and prevent post-therapeutic neuralgia, which is persistent nerve pain. Pain management is also key.
Got it.
That dermatome pattern is key for shingles. Fungal infections next. Yep, fungal infections are also super prevalent. Like Taenia pedis, commonly known as athlete's foot, you'll typically see scaling and maceration, especially between the toes, maybe scaly patches on the soles. It's often really itchy and can be painful. Diagnosis is often confirmed with a KOH exam, potassium hydroxide prep of skin scratings, looking for fungal elements under the microscope. Nursing care focuses on topical antifungal creams or powders and teaching patients to keep the area meticulously clean and dry.
Okay, clean and dry for athlete's foot. Now, allergic reactions.
Right, allergic skin problems. Allergic contact dermatitis is common. It's a type IV delayed hypersensitivity response. It causes red papules and plaques, usually sharply defined to the area of contact and intensely itchy. The best treatment, really, is identifying and avoiding whatever substance triggered it, poison ivy, nickel, fragrances, etc. But then there are the really severe, life-threatening drug reactions, Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TTN. These are actually a spectrum of the same condition, differing mainly by the percentage of body surface area affected. Less than 10% is SJS, more than 30% is 10N. It's a rare but devastating immune response to certain medications, often starting 4 to 21 days after initiating the drug. Systemic symptoms like fever, cough, headache often come first, followed by the skin rash. It starts as a red macular rash, often with purpuric centers, that rapidly merges into blisters. Then you see this horrifying sheet-like detachment of the epidermis. Painful mucosal lesions, mouth, eyes, genitals are common too.
Wow, that sounds incredibly serious. What's the nursing priority there?
The absolute, non-negotiable first priority for nurses is to immediately identify and stop the offending drugs. Common culprits include sulfonamides, some NSAIDs, anticonvulsants. After stopping the drug, it's all about intensive supportive care, often in a burn unit setting. Focus on airway management, fluid and electrolyte balance, meticulous wound care similar to burn care, and aggressive pain management.
That's a chilling reminder of how vigilant we must be with medication side effects and potential reactions. And while not always life-threatening like SJ-STEN, we should also acknowledge benign skin problems, things like acne or chronic autoimmune conditions like psoriasis. Psoriasis, with its characteristic red plaques covered in silvery scales, it's not just a skin issue, is it? It can profoundly impact a patient's emotional well-being, their body image, their social life. It really demands our empathetic support. We need to address the body image concerns and mental health aspects alongside the physical treatment. It's a powerful example of how skin issues are truly never just skin deep.
Couldn't agree more. The psychosocial impact is huge.
Okay, so we've covered a massive range of conditions. Now, let's pivot. Let's talk about what we do as nurses for these integumentary problems. Let's get into the essential nursing management and the therapeutic interventions that really make an impact at the bedside.
Right. General nursing management for integumentary problems is really the nursing process in action. It's fundamental. It involves assessing a patient's risk factors and their actual skin problems, meticulously documenting everything we find. Diligently checking for any of those photosensitizing drugs we mentioned that they might be taking, providing crucial sun safety education, that's ongoing. Beyond that, it's about administering the prescribed therapies, whether it's topicals or systemics, to educating patients thoroughly on their treatments, how to use them, what to expect. And then, really importantly, vigilantly evaluating the effectiveness of those interventions to make sure we're getting positive outcomes.
So how do we translate those core principles into specific hands-on nursing interventions? Let's get practical. One common one is using wet compresses, right? Tell us about those.
Yeah, wet compresses, sometimes called wet dressings, are fantastic for superficial skin problems. They're great for reducing inflammation, soothing itching, helping with infection control, and gently removing crusts and scabs. To apply one correctly, you typically use several layers, maybe 4 to 8 layers of clean cloth material. Gauze works well. Make it slightly larger than the area you're treating. Soak it in tepid tap water. Sometimes cool water is used specifically for its anti-inflammatory effect. You apply it intermittently, usually for about 10 to 30 minutes at a time, several times a day, as ordered. A key point: always replace the compress with a freshly soaked one. Don't just pour more solution onto the old one. And of course, regularly assess the skin underneath for any maceration or discomfort.
Okay, replace, don't re-soak. Got it. What about for larger areas?
For larger areas, baths can be really beneficial. They help with relaxation and can significantly reduce itching. You can add soothing agents to the bath water, like colloidal oatmeal or sodium bicarbonate. Patients should soak in tepid, not hot water for about 15 to 20 minutes. And here's a crucial tip for maximizing the benefit. After the bath, gently pat the skin dry. Don't rub. Then, immediately while the skin is still slightly damp, apply emollients or any prescribed topical medications. This helps seal in the moisture.
Immediately after patting dry. Okay, that makes sense. And then there are all the topical medications, creams, ointments, gels.
All right.
How do we navigate those?
Good question. Their effectiveness really depends heavily on the base they're prepared in. It affects absorption and feel. Creams are emulsions. They're pretty versatile, good for many things. Gels are non-greasy, often alcohol-based, good for hairy areas like the scalp. Lotions tend to be cooling and drying, good for large areas too. Ointments are more lubricating and occlusive. They form a barrier, good for very dry skin. Pastes are thicker, more drying than ointments. Powders, well, they promote dryness and reduce friction. The general rule for application is a thin film applied to clean skin, spread evenly in the direction of hair growth, if applicable. Sometimes, occlusion covering the area with plastic wrap after applying medication, especially corticosteroids, can significantly boost absorption. But, and this is important, you should not use occlusion over areas prone to infection, because trapping moisture can make infection worse.
Right, no occlusion if infection's a risk. Okay, this leads perfectly to managing pruritus, or just itching. It seems like such a simple symptom, but it can drive patients absolutely crazy. Why is it so intense sometimes?
Well, it raises an important question. The sensation of itching is actually carried by the same non-myelinated nerve fibers that carry pain signals. So it's a potent sensation. Itching can definitely worsen from things like dry skin or physical stimuli like rough clothing or chemical irritants, and it often significantly interferes with sleep, which just makes everything feel worse. Our nursing interventions are really key here. Encourage a cool environment. Heat makes itching worse. Promote skin hydration, both orally and with moisturizers. Wet compresses can provide temporary relief, and applying moisturizers frequently is crucial. Some topical agents contain things like menthol, camphor, or phenol, which can provide a cooling or numbing sensation to block itch receptors. Systemic antihistamines can help too, especially the sedating ones at night, because itching often peaks when people are trying to sleep. And crucially, advise patients to avoid anything that causes vasodilation like hot baths or showers. Excessive heat or vigorously rubbing the skin as this can really exacerbate the itch.
Avoid vasodilation, keep cool, moisturize. Got it. Preventing the spread of infection and avoiding secondary infections seems like another huge nursing responsibility here.
Absolutely massive. While not all skin problems are contagious, basic infection control practices are non-negotiable. Always wear gloves when examining or managing open wounds or lesions with any drainage. Meticulous hand washing before and after patient contact is our single best defense. And proper disposal of soiled dressings is critical. We need to be able to educate patients about common contagious lesions. Think impetigo, staph, and strep infections, including MRSA, many fungal infections, scabies, pediculosis, lice. And teaching patients to avoid scratching is vital. Suggest keeping fingernails trimmed short. Scratching creates little breaks in the skin, called excoriations, which are perfect portals for pathogens to enter and cause a secondary infection.
Makes sense. Trim those nails. What about after procedures, like a biopsy or an excision? What should we tell patients?
Great point. Providing clear post-procedure care instructions is essential. Patients need to know what to expect and when to worry. Teach them how to distinguish normal signs of inflammation, maybe slight redness, swelling, tenderness for a few days, from signs of infection. Red flags for infection would include redness that persists longer than a week, or redness that starts spreading outwards, maybe more than a centimeter beyond the wound edge. Also, a fever over 101 degrees Fahrenheit, increasing pain, pronounced swelling, or any kind of purulent pus-like drainage. Those all warrant a call to the provider. And remember this principle. Keeping wounds moist and covered generally promotes faster healing and leads to less scarring compared to letting them dry out and scab over.
Moist wound healing. Okay. Now, something we touched on earlier but needs emphasis, the psychologic effects of chronic skin problems.
Yes, we must never overlook this. Visible lesions, especially on the face or hands, can cause significant emotional stress. They can profoundly impact a patient's body image, their self-esteem. This can lead to social isolation, problems with employment, and can even affect intimacy and sexuality. Our nursing role here is truly holistic. We need to provide support, create a safe space for patients to verbalize their feelings without judgment. And we should know about resources, like referring them to dermatology support groups. The American Academy of Dermatology often has links. We can also suggest cosmetic camouflage. There are specialized, opaque, smudge-resistant makeup products designed to effectively mask lesions and scarring. This can seem like a small thing, but it can significantly improve a person's self-perception and their quality of life, allowing them to engage more freely.
That's such an important aspect of care. Okay, just briefly, let's touch on some other advanced aspects nurses might encounter. Cosmetic procedures and skin grafts.
Right. These represent a broader scope of managing skin health and restoring function or appearance. Cosmetic procedures range widely, from topical treatments nurses might see discussed, like tretinoin, retin-A, or chemical peels, maybe microdermabrasion, to more invasive surgical interventions like facelifts or liposuction. For nurses managing patients undergoing cosmetic surgery, our role is pretty crucial both before and after. Preoperatively, it's about ensuring informed consent, but maybe even more importantly, helping patients establish realistic expectations about the potential outcomes. Managing expectations is key. Postoperatively, our focus shifts to managing pain, which is usually mild but needs attention, meticulously assessing for any signs of infection, and critically monitoring circulation to the surgical site. We're looking for warm pink skin that blanches easily when pressed, indicating good blood flow. Applying supportive dressings or using ice packs as ordered is also common postoperative care.
Realistic expectations, monitoring circulation, got it. And skin grafts, when are those used?
Skin grafts become essential in several situations. To protect underlying structures like tendons or bone after major trauma or surgery, to reconstruct areas damaged by burns, trauma, or cancer removal, aiming for both cosmetic and functional improvement, and to facilitate wound closure when wounds are simply too large to heal effectively on their own through primary intention or granulation. There are different types. Free grafts involve transferring sheets of epidermis and maybe some dermis from a healthy donor site to the recipient site. The graft has to develop a new blood supply there. Then there are skin flaps, which are more complex. These involve moving a section of skin and the underlying subcutaneous tissue while keeping its original vascular attachment intact. This ensures immediate blood supply. And we're also seeing more use of engineered skin substitutes. These are lab-grown products that can offer advantages like ready availability off the shelf, no need for a donor site, which means less pain and scarring for the patient, and potentially better cosmetic outcomes.
Fascinating. Skin flaps, engineered skin. Sounds complex.
It is. And we connect this back to the bigger picture. These advanced therapeutic approaches, from the targeted drug therapies for melanoma we discussed, all the way to these sophisticated reconstructive techniques, they really underscore just how evolving and complex the field of integumentary care truly is. It just reinforces the critical need for us as nurses to engage in continuous learning. We need a really comprehensive understanding of the skin, not just as an organ, but as this crucial component of a patient's overall health, function, and well-being.
Wow, what an incredibly comprehensive deep dive into integumentary problems. Seriously, that was packed. We've covered everything from the critical impact of sun exposure and how to recognize skin cancers using those ABCDEs, to managing common infections and allergic reactions, remembering those honey-colored crusts and dermatomes, and touching on the profound psychological effects of chronic conditions. Not forgetting SJSTEM, that was sobering. The main clinical takeaways for you, our future nurses listening, seem clear. The absolute critical role of the ABCDE rule for early skin cancer detection. Those specific hands-on nursing interventions for managing infections, allergies, itching like wet compresses, and immediate moisturizing after baths. And the crucial need for holistic support for patients grappling with chronic skin issues, addressing their emotional well-being too. This deep dive has definitely given you a much more robust toolkit for integumentary care, I think.
Absolutely, I hope so. It really just highlights the importance of vigilant assessment, proactive patient education on prevention that's huge, and skilled nursing management in achieving those positive patient outcomes. We always have to remember to address both the physical and the psychological well-being of our patients. They go hand in hand, especially with skin conditions.
Precisely. Well said.
Okay.
So here's a final thought for you to consider. Think about how our understanding, our management of skin conditions, not only treats the physical ailment itself, but also profoundly impacts a patient's self-perception, their confidence, their quality of life. So what single change could you make in your own daily routine starting today that could have the biggest impact on your skin health? Or, looking ahead, what change could impact that of a future patient you'll inevitably care for? Something to mull over. Thank you so much for joining us on this deep dive.